Hello, everyone, and welcome back to CSAIL Office Hours. I am Daniela Roos, the director of CSAIL, where we are inventing the future of computing and making the world better through computing. Today, our focus will be on health and how computing and AI can help with diagnosing, monitoring, and treating disease. Dina, you have made so many impactful contributions to communication and to understanding wireless signals. How did you think to move from studying networking to applying wireless signals to the healthcare sector?
Maybe about 8 years ago, we started looking into how we can use radio signals to monitor physiological signals. So that was the early set of results, basically just understanding that radio signal bounce around and they bounce off the human body because we are made of water. So a signal comes and reflects. And then if you analyze those reflections, particularly if you analyze them with the power of neural network and machine learning, you can start learning things that you couldn't imagine that these radio signals around us have or carry about us, such as, of course, our respiration, the pulsing of our blood. Even when you go to sleep, we can tell whether you are in the dreaming stage, for example, REM, versus you are in light sleep or deep sleep. And then that took us to the next generation, not just monitoring the physiological signals of people using radio signals without touching them, but also collecting that data and starting to develop neural network model for diagnosing and tracking, like what's called biomarkers of diseases for Parkinson's, for other neurodegeneration diseases. And the most recent thing is Gen AI for medical data.
With your algorithms and your insights in wireless networking, you can see what we cannot see with the naked eye. How does this work?
It takes many years to diagnose Parkinson. Like somebody may have Parkinson 10 years ago and they haven't been diagnosed because one of the issue is that you wait for the motor symptoms. You know, in Parkinson, the tremor, the stiffness of the motion. And these motor symptoms appear late in the disease. By the time the motor symptoms appear, the dopamine neurons, which are the neurons involved in Parkinson, about 40 to 80% are already damaged. When we learned this, we were just like, oh, but can we diagnose it from other signals? Now that we have these devices in people's home, and we just take the wireless signal, maybe from wireless we know that we can get people breathing, and let me just try to detect whether they have Parkinson from their breathing, because there are some hypotheses that breathing is impacted by basically that Parkinson comes from the guts along the vagus nerve, and then it hits the breathing area in the brain, so breathing changes earlier. But actually it turned out that you can diagnose, or machine learning algorithm can diagnose Parkinson with high accuracy from someone's breathing.
What is it at the intersection of understanding wireless signals and understanding machine learning? What is it at this intersection that helps you solve this problem?
We are not trained to look at radio signals, but machine actually, when you train them with the right output, they can sense the signal and they can start seeing patterns that the human brain is not trained to see from sensory signals that we don't have, like electromagnetic waves.
Where does this data come from, the data that you use to train your models?
We designed a device that looks very much like your Wi-Fi box at home. So it sits in the background of the home. And it's like analyzing these radio reflection, transmit very low power wireless signal, analyzes the reflection, and analyze them with neural networks. And from that, it can be like, you don't have to wear devices on yourself. People can live their lives and you can just get all of that insight to clinical data. But it also conveys the information to the medical doctor, to the practitioner who's the expert, and can help them.
Can this model monitor for multiple diseases, or is it finely tuned for Parkinson's?
Monitors multiple diseases. Particularly interested also, I find the biggest opportunity is in neurology and immunology. So it's very hard to study neurological diseases. Even things like depression. I mean, we ask people, how do you feel? But give you like a drug or treatment. There is no actual concrete measurements to do that. that's where we are seeing like our results from being able to concretely and objectively measure the physiology of the person and how it changes. We can see major opportunity to have a what's called biomarker in this context, a digital biomarker for these complex diseases.
Can you tell us a little bit more about immunology? What are you looking at in this space?
One essential thing of the immune system is that you are talking about a dynamic system, a system that is changing. Like it's just your immune response, it's a response. Flare-ups, there are flares, you change, you are in remission. If you have like an autoimmune disease, you are in remission and then you have a flare. But in the whole medical system, we don't have like all of the tests that we do are snapshots. Like I know we talk in computer science, we talk about snapshots versus like continuous tracking. We don't have the continuous tracking and clinical data for that continuously can track a dynamic system like the immune system. There is a huge opportunity here to be able to move from snapshots, particularly when you are talking about inflammatory response, immune response, to continuous data, and where we can see where we are using our devices and AI and to track these changes.
So are you finding that the Wi-Fi signals reflect differently if there is an immune system flare-up?
When they bounce off my body, your body, the environment, they change based on everything. Your respiration, the pulsing of the blood, the twitching of your eyes, like different muscles, all of the behavior that we have, and things that we don't even think as behavior. So the physics of how the reflections happen don't change. But when you extract this information from those reflections, now those change. Your respiratory system response to inflammation is going to be different. Your sleep and sleep patterns would change if somebody has a particular disease or is taking a particular drug. So those then, you can think about AI in two levels. One level is like taking radio signals and extracting from the physiological signals. And then another level of neural networks that takes those physiological signals, continuously extract it from the radio signal and start talking. Does this person have Alzheimer's? Does this person have Parkinson? How did their Parkinson change? Are they taking antidepressant? Are they responding to the antidepressant?
How do you use generative AI to get to better results?
Being able to take some simple signals, let's say like something from your Fitbit or some like your pulse or something, and transform that using generative AI to clinical tests. That was the use of generative AI that we are looking at. And we actually do have initial data that shows that this is doable. And actually the generated data is very much similar to the actual real data from the medical test for that person.
Your generative AI system for medical data, what is the raw data used to train it?
We move from one medical modality that is cheap to a medical modality that is expensive. A cheap medical modality, it's kind of like a wellness modality. Like if I take the PPG from, like the pulsing from like AOS device or, the breathing from radio signal. These are cheap, available and easily. And from that, I generate something that is expensive, like an EEG signal, for example, for the brain.
Dina, it sounds like you have invented a new technology that is non-invasive and that gives doctors a kind of a superpower because it allows them to see things that are impossible to see with today's technologies.
In medicine, I think there's a huge potential for computation in general. I think even without AI, there are plenty of opportunity for computation. But with machine learning, also the opportunities go even higher.
Thank you for putting so much thought and effort in making healthcare better. Let's go meet MIT professor John Guttag. John has been working with artificial intelligence and machine learning to develop the field of healthcare informatics. And he has been looking at how machine learning can enhance the diagnosis of cardiac disease.
My first work in healthcare and AI was in cardiovascular medicine. And I had the good fortune that Colin Stoltz, who's a member of CSAIL and a faculty member in EECS, is also a practicing cardiologist. Colin and I have been looking a lot at, can we use non-invasive signals to get good approximations of data that is usually gathered invasively? So the best example is probably an ECG. Measures the electrical activity of the heart. Every patient in the hospital typically has an ECG connected to them. What's been interesting is the things you might not expect to be able to get out of that signal, but we think you can with the right kind of technology.
Machine learning?
Machine learning to learn it, but then, of course, when you're running it in practice, you have to have forward passes that run fast.
The role of machine learning is to train a model that will give the right predictions. Is that right?
We use machine learning in healthcare in a lot of different ways. Sometimes it's used to train models that we'll actually deploy, but other times we use it to do what I'll call science and learn about things. And once we've learned about them, then the model, maybe you don't need it anymore. You've learned something, you've done some experiments, it's helped you learn things. If we think of machine learning as you generating hypotheses that can then be tested in clinical settings or in the lab, then you don't have to trust the model, because all the model is doing is giving you things that you're going to test. Once the model finds hypotheses, you can then maybe look for mechanistic explanations or look for rules. Maybe it's just discovering a rule and you can explain the rule to somebody and say, oh yeah, that's a sensible rule. And so I think a lot of the use of machine learning today in healthcare is in the science part of it, where we're discovering things that can then be used in the clinic. We started with communicable diseases, and we did that in conjunction with MGH, with the infection control department there. So the infection control department's responsibility is to reduce the incidence of healthcare-associated infections in the hospital. We were approached to look at the question of, could we use machine learning to find ways to reduce the prevalence of healthcare infections in the hospital? And the one we focus on to start with was C. diff, which is the most common one. It's an intestinal disease, bacterial disease. Our models predicted which patients were most likely to contract the disease. If you know that someone is likely to contract the disease, you'll be more aggressive about knowing when to test them. And that will let you discover they have it sooner and start treatment sooner. And so what we did is we built models that were quite effective at determining which members of the population were most vulnerable. So if we look at what makes people susceptible, some of what we found was already known. When some antimicrobials increase the likelihood of contracting C. diff, and some more than others. We found zip code was important. Now you say, well, how on earth can where a patient lives matter? Some of what they think of hospital-acquired was actually the bacterium was already in the patient's system, and then something that happened in the hospital allowed it to flourish and get worse. And so the bacterium came from the community, right. And it was, say, the treatment in the hospital that made it flourish. Suddenly it made sense, and we looked at these zip codes, and for example, they were often zip codes that had a lot of nursing homes in them.
So John, for this work in communicable diseases, can you tell us a bit about the techniques that you have used, about the computational aspects of the solutions?
One of the things that's interesting about a communicable disease is the fact that you need exposure. And that means you have to look at network effects. And a lot of machine learning algorithms don't really deal with networks. And so a lot of what we did was looking at connectivity networks to try and build models based upon that.
And you use machine learning for that?
Yes.
How did you train your models?
We were able to get access to all of the MGH patient records. You can look at the patient record and see which nurses are visiting which patients. which doctors are visiting which patients, where they are. We actually looked at the architecture of the hospital. But the most important network was the caregiver network.
What are you working on right now?
The biggest investment in my lab right now is in medical imaging. And machine learning is in the process of totally revolutionizing medical imaging. So if you think of the amount of data produced by an MRI, it's three-dimensional, high resolution typically, and it's more data than a human can possibly look at. There are a small number of tasks that you have to do for any kind of image. One of them is segmentation. So that involves you take an image and you find regions that are anatomically significant and separate them from the rest of the image. So segmentation is very important, but not just for things like tumors. For a lot of, say, neurological diseases, you want to look at the shape of, say, the hippocampus. What is its exact shape? Is the shape changing? And to do that, you have to find it and segment it very precisely. We have built something which we call Universeg, Universal Segmenter. It's important because the other universal segmenters that are out there, and there are quite a few, work only for natural images, really. They don't work very well for medical images. And you need something that's very broad because there are an enormous number of different modalities, ultrasound to X-ray to MR to optical to OCT, all sorts of things. We collected an enormous amount of data from many different medical imaging modalities, many different tasks. We then invented ways to generate synthetic data. If you look at our synthetic data, it doesn't look like any medical image anyone has ever seen or any task anyone has ever seen. But it prevents the model from overfitting to the actual tasks you show it during the training. Our other thing we've done with Universeg is it's what's called context-based learning. At inference time, when someone is trying to, say, segment something that they don't know how to segment, what we do is you give it a small number of examples. And that's used as a prompt to say, oh, that's what they're looking for. And then based upon that small context and all of the other examples it's been trained on, it then can generate quite good segmentations. And we think eventually it will be as good. Right now, if you train a one-of model for one modality and one anatomy, it's slightly better than the universal segmenter.
As you think about computational tools and their potential in healthcare, where do you see us going in the next 3 to 5 years?
The large population studies will be the first thing impacted, I think, by a lot of the machine learning technology. And I think it'll have enormous impact on things like telemedicine. Instead of having a person move to the clinic, we acquire data and send the data to a computer, and the computer looks at it. And I think we can make very quick inroads in using machine learning to build models that will improve the healthcare system. If healthcare gets less expensive, we'll get better outcomes. An awful lot of people don't get the treatment they need today because they can't afford it. If we can reduce the cost, it isn't just saving money, it will give us better outcomes.
John, thank you so much for sharing with us your work, your results, and your wisdom about the use of computational tools in healthcare. Now, let's go to see what Professor Marzyeh Ghassemi has been up to. I want to start by asking you about your work in rule violations. And so you have shown that AI models fail to reproduce human judgment in identifying rule violations. What is this all about?
Well, the issue is that when we label machine learning data sets in standard settings, we're always asking people if a feature exists. Is a dog big or is a meal sugary? But that's not actually why we train machine learning systems. We usually train them to predict a violation of some rule. is this meal too sugary for the school rules? Or is this dog too large for the building's rule? And so in that setting, it's really important that we tell people you're going to be judging whether a dog is large for a rule violation, because what we found is that people's judgment of whether a dog is large actually flips when you tell them that it's being used to create a rule in a machine learning system.
How does this translate to medicine?
If we have labels that don't reflect the ultimate judgment that's being made, it's possible that some people will be denied services that a human judgment would have given them in the first place.
So what can we do about this?
We can look at giving more specific prompts to people who are judging whether a feature is present in an image or in text or in tabular data, and let them know that this judgment will be used in a specific human rule setting. And when they have that context, we think that they'll make better judgments, so we can have machine learning systems that mimic human judgments. What we found is that when you try to improve the models that are using this data, you have to make assumptions about how harsh the system should be. And so when we looked at algorithmic improvements, if you can make good guesses about where the threshold might be for the data. So for example, I know you've labeled this feature about a large dog factually, but if I asked you subjectively whether it's a large dog in violation of a rule, if you can guess what that would do to somebody's judgments, then you can try to fix some of this on the algorithm side.
But couldn't you tweak it too much the other way? So couldn't the system be abused then?
That's why we think there needs to be a holistic difference in how we gather these labels in machine learning data sets. You can't fix it all with the algorithm. This is something we really need to change from the ground up.
And how would this look for medicine?
Well, in medicine, what we've been looking at recently is how we can give doctors descriptive or prescriptive recommendations for different kinds of actions. When you think about the ways that you could give advice to somebody, usually it's based on an if-then rule. So if the meal is sugary, then it's a rule violation. Or if the patient has a risk of mental illness, then refer them to a psychiatrist. And so we wanted to look at whether these descriptions of whether a meal is sugary or a dog is large were the right thing to give a patient or their advocate versus the judgment, this prescriptive action of saying that a dog is in violation or a meal is in violation or a patient should see a psychiatrist. And so what we did is we looked at different settings such as mental health crisis lines where you could either say that a patient has a risk of violence or that you should call the police to help that patient. And we wanted to look at what happened when we gave very biased advice from an AI system to doctors, either descriptively, saying there's always a risk of violence for minorities, or prescriptively, saying you should call the police on minorities consistently. What we found is that if you give really biased AI advice to doctors in a descriptive way, you just say that there's a high risk of violence for all the minority patients, doctors don't listen to it. They retain their original fair judgment. But when you tell them to call the police disproportionately, then they do listen to it. So this prescriptive recommendation that tells you what to do somehow short circuits critical thinking skills. And so in health specifically, we need to think carefully about not only what predictions we're making, but also exactly how we deliver those predictions. And what we find is with these descriptive systems, you're giving them the rules and they're able to follow through on these judgments and have really good critical thinking skills. But when we give them the end result, just shortcut to the answer, they don't actually go through the process. And so they miss mistakes that the model might make. And so it's crucial that when you have a system helping people, it helps them through the thinking process, not through this sort of efficient shortcut that they could have. We find that when people are very good at the task, then you can train a machine learning system based on past labels in this data. And then that model will be so good that you could probably just use a prescriptive system and say, go ahead and follow the model. We think that most of the data we have, while it's good, it has errors, it has flaws, there's variation. And so we want people to continue to understand how to make these decisions with advice, but not always follow it.
Now, in addition to descriptive and prescriptive solutions, you're also considering normative solutions.
Normative solutions are things that we believe that people should do in most cases that others have judged as being the right decisions to make. This doesn't always happen in a healthcare setting, but there are some really well-established care pathways you can look at in machine learning for health where we know the right things to do. We want to reduce the variation in how different patients are treated and have a more normative solution because we know the right answer.
So how do you go from descriptive and prescriptive to normative?
For many chronic conditions, there's huge variation. One person's diabetes is not another person's diabetes. One person's pregnancy is not a person's pregnancy. And so because there's a length of time over which you have different complications, there's going to be so much room for variation. But a septic patient is often a septic patient. They're so acutely ill that the way that you can treat them, the number of levers you have to pull, they're very small, and the variation is also very small. And so we'd like to have more normative actions.
This work is so important, and it raises such profound ethics issues with deploying AI in medicine.
When you give advice to somebody who's already bound by an ethics code, as all clinical staff and clinicians are, what is your additional responsibility as a technical person who's contributing to their interaction with a human system? There's no easy answer, but what we're trying to do right now is understand where all the biases in the process are, from collecting the data to defining the labels to developing the algorithm to deploying specific advice. And we think by codifying those and auditing them and letting the people actually using the systems know what's happening, we can have a better end-to-end system where doctors make those judgments.
What else are you excited about? What's the future in your lab?
Having systems that can flag incorrect data from the get-go in large systems in an unsupervised way. This is definitely a problem in health. It's also a problem in places like computer vision, where we know that images of abuse and inappropriate treatment make it into large image data sets. And then if you're not looking through these huge sets of images, they can make it into downstream models. So if we have systems that can successfully audit data sets, then we can have a better set of data to learn from the beginning. And then all the way on the other side, I'm really excited about understanding how we can take deployments and deliver advice in a way that doesn't perpetuate biases, but helps clinicians create more equitable healthcare systems within their practice. We don't want to create supervised systems for identifying bad quality or inappropriate data within these large data corpora, because that just doesn't scale. Instead, what we want to do is look at the different views of data that exist within large-scale embedding spaces, and then use these different views as self-supervised learning, where one view of an image is contrasted with another view. And we think that differences between the ways that different models view data will highlight when data is inappropriate or incorrectly labeled.
Marzyeh, that sounds so interesting and important, and I can't wait to hear about the new results.
Thank you for having me.